So, our next lecture is medical management of the surgical patients with cardiovascular disorder. This lecture it came in the three parts. Today we'll discuss the first part, and within the next week we'll discuss the remaining two. Because of the advances in the medical treatment and the medication for patients with chronic disease, the expecting life of patients with cardiovascular disorder have been greatly increased within the recent years. So it's become more common for us to see such patients with these comorbidities in our dental clinic, which requires dental treatment. Patients who are referred to as hypertensive have a persistent increase in blood pressure over 140 systolic on 90 diastolic. The causes of hypertension can be either primary, which is referred as essential hypertension, for which the cause is unknown, but there are several contributing factors like, for example, genetics, alcohol, salts, obesity, which are all thought to be a contributing factor for the development of a primary hypertension. On the other hand, secondary hypertension, where the underlying disorder that causes the hypertension is known. For example, if patients have renal disease, sometimes pregnant patients, steroid therapy for long time, or sometimes a rare endocrine problems like Cushing syndrome or pheochromocytoma. These can cause a secondary hypertension. The classifications of the hypertension can be classified into stage 1, stage 2, and stage 3. So hypertensive patients might fall in one of these categories. The dental management, on the other hand, for each category, different from one patient to another. For example, if we have patients who have a systolic pressure between 140 to 159 on a diastolic pressure between 90 to 99, these patients fall within stage 1 hypertensive stage. For such patients, we need to recheck the blood pressure at each visit, and routine dental care can be done. If the patients have a blood pressure less than these numbers, then nothing needs to be checked and routine dental care can be done straightforward. While on the other hand, the blood pressure is greater than these numbers, for example, from 160 to 179 systolic on a diastolic from 100 to 109, these are stage 2 hypertensive patients, and then special precautions need to be taken. We need to recheck the blood pressure at each visit, and medical consultation should be obtained from the supervising physician before giving any dental treatment. The amount of the local anesthesia with adrenaline is limited, and sometimes if we have conscious sedation, like for example nitrous oxide or IV sedation, then these might be beneficial to reduce the stresses and prevent the elevation of the blood pressure. If the patients fall within stage 3 hypertension, then we need to recheck blood pressure at each visit, and only emergency dental treatment can be done. No routine dental treatment can be given to such patients. Medical consultation should be taken, and vasoconstrictors can't be used. So if we want to give an anesthesia to such patients, it's best to give a plain anesthesia without vasoconstrictor. So as we can see, the dental management for each category differs from one to another. So for hypertensive patients, we should know the blood pressure readings before we can commence our dental treatment. Sometimes patients who are hypertensive on a variety of medications. These medications might cause oral manifestation, and sometimes the patients might come to our clinic complaining of these manifestations. So it's important to know the adverse effects of antihypertensive drugs. Antihypertensive drugs might cause xerostomia, which is dry mouth. Can be seen with patients who take thiazide diuretics and angiotensin converting enzymes inhibitors like captopril. The incidence and the severity of xerostomia increased with the dose of these medications and if these medications are taken together. Also, certain medication like calcium channel blockers might cause gingival hyperplasia. Gingival hyperplasia, as you can see here, this is caused by nifedipine, and the patient might seek dental treatment for it. The gingival hyperplasia is dose related, and sometimes we might refer the patients to their physician to adjust the dose or change the medications to get rid of this side effect. Lichenoid drug reaction can be caused by many of the antihypertensive drugs and manifest as white patches, sometimes on the cheek, on the buccal mucosa. These include thiazide diuretics, furosemide, propranolol, and captopril. Another manifestations of the antihypertensive drugs are the postural hypotension. Postural hypotension can be caused by antihypertensive agents. So it's necessary to raise or change the posture of the patients slowly. So if we, for example, work in a supine position, we need to make the patients in an upright position slowly. If we raise the backrest fast, then the patients might have a postural hypotension. We have also sometimes an interactions between the drugs that is used in dentistry and the antihypertensive agents. For examples, we have the epinephrine in local anesthetic agents. Sometimes its side effects potentiated by the use of the non-selective beta blocker. So some would suggest a maximum of 2 cartridges of local anesthesia with adrenaline for such patients who are on non-selective beta blocker, for example, propranolol. And if we need any further injections, it should be given as a plain anesthesia. Others would suggest the importance of the use of epinephrine containing local anesthesia for such patients because the epinephrine, the vasoconstrictor, will aid in giving a more profound anesthesia for such patients. Therefore, the patient will feel more comfortable during the dental procedure and less stresses will be anticipated. The stresses, on the other hand, will cause the blood pressure to be elevated during the dental visit. Also, we have an interaction between the non-steroidal anti-inflammatory medications and the diuretics, beta blockers, alpha blockers, and angiotensin converting enzymes inhibitors. Non-steroidal are given as painkillers during the after the dental interventions. For example, if we give ibuprofen, paracetamol, these are all non-steroidal anti-inflammatory medications. The prolonged use of non-steroidal anti-inflammatory medications like ibuprofen might interact with the action of these antihypertensive medications and antagonize their actions, while paracetamol don't have this side effect and can be safely used after the dental visit. Another part for patients complaining of cardiovascular disorder is the ischemic heart disease. Ischemic heart disease occurs when the oxygen supplies to the myocardium is insufficient for its demand. The cause of the ischemic heart disease are thought in the beginning that there is a hard plaque that is growing within the lumen that obstructs the blood vessels, the coronary arteries, while in fact there is a more recent theory that suggests that there is a lipogenic core, a soft plaque, that is being grown within the lumen. And when it's reached a big size and ruptures within the lumen, this lipid material is a thrombogenic material and will be exposed to the bloodstream and causes platelet aggregations and thrombus formation, which in turn will obstruct the lumen of the coronary arteries. This might cause either an angina pectoris, which is the symptoms of ischemic heart disease, or more severe myocardial infarction. There are certain risk factors which might contribute for the development of ischemic heart disease. For example, a positive family history, being a male, patients with diabetes mellitus, elevated cholesterol level, and hypertensive patients. Cigarette smoking is also a contributing factor for the development of the ischemic heart disease. Ischemic heart disease can be either in the form of angina pectoris or, as we say, the more severe myocardial infarction. Angina pectoris is the sensation of the ischemic heart disease. It has the sign and symptoms of the ischemic heart disease. The patients might feel a sensation of choking, squeezing, and tight feeling within the substernal region. Sometimes this pain might have a radiation. The radiation usually to the left shoulders and sometimes within the jaw and the throat. This happens when the supply of the oxygen to the myocardium is below what its demands. If this can be controlled by medications and only aggravated by exertion, this can be referred as a stable angina. If it is aggravated by either at rest or poorly controlled by medication, it's referred to as unstable angina. If it becomes more persistent with more severe manifestations, the patients might have myocardial infarction. The dental management of these patients different from one category to another. For example, if we have patients with a stable angina, as we said, stable angina, which can be controlled by medication and usually aggravated by exercise or stresses, okay? These patients, we need to consult with their physician, and the pulse rate and blood pressure needs to be taken before each visit. We ask the patient to bring his or her nitroglycerin, the GTN tablets, to be used, the sublingual GTN tablet, to be used before the dental treatment. As a prophylactic measure, are sometimes to be asked by the patient to use it when the symptom of the angina came during the dental procedure. These patients should have adequate pain control by local anesthesia with vasoconstrictor with a maximum of 2 cartridges, as we said. And if we need to add further local anesthesia, it should be without vasoconstrictor, a plain anesthesia. An anxiolytic like diazepams might be beneficial to reduce the stresses during the dental procedures. Inhalation sedation, as we said, also can be beneficial because inhalation sedation will contain oxygen, nitrous oxide with oxygen supply. So it will give the patients more oxygen, and also the nitrous oxide will minimize the stresses during the procedure. It's best to put the patient in a semi-supine position, and the dental treatment best to be limited to 30 minutes. There are certain timing where the blood pressure is at the lowest possible during the day, and it's the best to use this time for the treatment of those patients. Usually, this is between the late morning and the early afternoon period. And why is that exactly at this time? We know there is something referred as the circadian rhythm. This is like our biological clock. And as we said, between the late morning and the early afternoon, okay, during about this time, the blood pressure is at the lowest possible. If we notice here at the early morning, we have the sharpest rise in the blood pressure. And as early as this, we should avoid dental treatment because in the morning, in the early morning, we'll have the sharpest rise in the blood pressure. While late morning is best to be used for the dental treatment. Early afternoon also have the lowest blood pressure, while late afternoon also have a sharp rise in the blood pressure, and also dental treatment late as this should be avoided as well for patients with cardiovascular disease. So it's best to use either an early morning or a late morning, or an early afternoon procedures appointments for these patients. Patients with ischemic heart disease. As we said, the treatment is different for each category. For example, if we have patient with unstable angina, if the patients have unstable angina, they only can receive emergency treatment only. But if the patients have history of myocardial infarction, the management is different. If it is more than 6 months, we can manage them similar to what we have just talked about stable angina in the previous slides. If it is less than 6 months, is similar to unstable angina. So if we have patient with myocardial infarction that happens, for example, 2 months ago, we should only deliver emergency treatment with the consultation of the supervising physician. If we have patients who have a myocardial infarction that is more than 6 months, then we can treat similar to stable angina. So we ask the patients to bring their medication with them. We ask the patient to present to the dental treatment at a late morning or early afternoon appointment in a semi-supine position, and we limit the use of vasoconstrictor in our local anesthesia. We also need to check the blood pressure and also check the pulse rate before the treatment. Why this? We take this 6-month period between the history of the myocardial infarction and the extent of dental treatment we give. Because within the last 6 months, with recent history of myocardial infarction, we have like similar to something like a target lesions. In the center is the dead tissue of the myocardium, which have been affected by the myocardial infarction. While on the periphery, we have the myocardium, which have been stunted by the effect of the myocardial infarction and is still in the process of recovery. After 6 months, we assume that on the periphery of the center dead myocardium, on the periphery, the muscles have gained its, for example, what we can say, its recovered from the effect of the myocardial infarction. And then we assume after 6 months, we can safely administer elective treatment to such patients. Now, if we have a chest pain during dental procedure, what we can do if we have a patient who develop a chest pain during a dental procedure. By following this chart, we'll understand the process, how to manage patients who have a chest pain during a dental procedure, we need, in the beginning, we need to stop the treatment immediately. Administer glycerate trinitrate and oxygen for these patients. If the pain disappears, then we might consider continuing our treatment or give another appointment. While if the pain persists despite the GTN and the oxygen being given, then after 5 minutes we can give another glycerate trinitrate, either in the form of a spray or a sublingual tablet. If the pain disappears, then we go and consider treating the patients or give another appointment. If the pain persists even after 5 minutes, we give another GTN until a total dose of the 3 GTNs administration, and after 15 minutes, then if the patient still have a chest pain during the dental procedure, then we suspect an acute myocardial infarction. Aspirin should be administered and immediate transfer of the patient to hospital is advised. Patients with cardiovascular disease are on different types of medications. One of these groups of medication that we taken by these patients are the antithrombotic medications. The antithrombotic medication can be either in form of antiplatelets like aspirin or clopidogrel, the Plavix, or sometimes it is an anticoagulant medication, for example, warfarin. The dental management of these patients differs depending on the medication taken. For example, if the patient's on an aspirin, a monotherapy, only an aspirin, we need to measure their bleeding time. And the current recommendation is to avoid the interruption of the medication. So we send the patients for bleeding time measurements, and then we decide if we want to deliver the treatment. Usually the bleeding associated with aspirin is mild bleeding and usually can be controlled by local measurements like pressure packs. We give the patients a pressure pack, piece of gauze, and ask them to bite on it on the bleeding spot, and usually this would be sufficient to stop the bleeding. Why we avoid the interruption of these medications? Because the risk of bleeding postoperatively is low, while the risk of developing a thromboembolic event, like for example myocardial infarction, okay, is high, and the consequences also is high. So it's best to keep the patients on their medications and take a good local measurements, minimal trauma during the extraction, ask the patients to measure their bleeding time, and commence with the dental treatment without interrupting the aspirin. While if the patient's on a dual therapy, if the patient takes an aspirin and the clopidogrel at the same time, the patients are at high risk for bleeding postoperatively, and hospital setting is best to treat such patients. On the other hand, anticoagulant medication warfarin, we need to measure the international normalized ratio, and then we decide if the patients can be safely given a dental treatment or not. The measurement of the INR should be done within 72 hours, 3 days, prior to any dental intervention. And if the patient whose INR below 2.5, it's likely to be safe to have a dental intervention without changing their medication. If it is more than 2.5, we anticipate a high bleeding risk, and the supervising physician might alter the dose of the warfarin before the dental procedure. If the patient's on a combined therapy in aspirin and warfarin, it's best to send the patient for hospital setting because the patient will be at an increased risk of bleeding postoperatively. Okay, thank you for your listening, and if you have any question, feel free to post them on the chat. I'll be more than happy to answer them. Thank you.